doctor, about Delphi score. I think that many clinicians are not familiar with Delphi score. So I hope that today, during our liver talk, we will know more about Delphi score. So to start, I would like to introduce Dr. Đào Y Doãn from Johns Hopkins, who is the first host for liver talk and support for all of the activities of the liver talk. So Dr. Doãn, please have a short introduction before we start our main content.
Great. Thank you, Dr. and Associate Professor Đào Việt Hằng. My name is Don Đào. So I just have a few thoughts, and then I will introduce the speakers and the moderators for today's session. This liver talks aims to keep up to date with the recently published work, including diagnostics, therapeutics, and discoveries of concepts in chronic liver diseases. The work can be in basics, science, translational research, or clinical research, as well as public health. And as you already heard, Dr. Hong mentioned about this new platform or technologies, Delphi score, that has recently been discovered, and it has potentials in cancers management, and particularly in our case, liver cancers. And I hope that you'll be finding it useful after Dr. Nicholas Dracopoli's talk and Dr. Amy Kim's talk. And eventually, we hope to translate these forefront knowledge to guide research and practice in chronic liver disease in Vietnam. And after we do all of this, hopefully we will be able to build a community of individuals, groups, and institutions who share a common interest in learning and conducting research in chronic liver disease, including liver cancers in Vietnam. So for today, we are really honored to have the participation and presentation by the US speakers, including Dr. Nicholas Dracopoli, who is co-founder and chief scientific officer of Delphi Diagnostic Company, a company that discover and has been commercializing this Delphi platform that you will hear momentarily. Here we also have assistant professor and physician scientist Amy Kim, who's my colleague. She's in our divisions at the Johns Hopkins University School of Medicine. From the Vietnam side, again, we are really all privileged to have the participation and the moderation from Dr. Hong Dao from Hanoi Medical University and Dr. Ngô Tắc Trung from the 108 Military Central Hospital in Vietnam. So with that, I transition my part to Hong and the speakers as well as Dr. Trung, and I hope you will find this session educational and helpful and potentially clinically relevant. So thank you.
So thank you, Dr. Doãn. So I hope that for the new participant who attended in our liver talk for the first time, you will be familiar with our format. We will have the presentation from the US speakers, and then we will have the discussions at the end, as well as a wrap-up session. So when you listen to the presentation, and if you have any questions, please feel free to send the question in the QA or in the chat box. You can write in Vietnamese or in English. In case you have a Vietnamese question, we would interpret after the session. So firstly, we would like to introduce Dr. Nicholas Dracopoli with the presentation on Delphi discovery. Please, Dr. Nicholas, thank you.
Okay, well, thank you, Dr. Hang, and thank you, Doan, for the invitation to present. I'm going to give a short presentation around this new technology, emerging technology for the early detection of cancer, and to describe really the basis of the approach, which is designed to be independent of mutations and doesn't require deep sequencing, so that we have the potential to deliver a much less expensive test with high sensitivity for the detection of cancer. Our colleague at Johns Hopkins, Dr. Amy Kim, will then provide a discussion of her recent work and the team's work on applying this technology for the detection of liver cancer. So my presentation will be really just focusing on the basis of the technology, the underlying molecular genetics, describe the test itself, and then I won't speak specifically about liver cancer, but we'll leave that to Dr. Kim in the following presentation. So if I can share my screen. Can you see my screen now?
Yes, but could you change into full screen?
Yeah.
Yes. Okay.
There we go. Great. So I'm going to speak about detecting cancer using this methodology called cell-free DNA fragmentation. And I think as many of you are aware, there's been much work done over the last few years on early cancer detection, primarily based on looking for canonical cancer mutations, but also looking at changes in the epigenetics of cancer cells by looking at DNA methylation. And so this is, the fragmentation is a third and different approach, but is really measuring some of the similar biological outputs of a cancer cell to identify cancer. So
Dr. Marcopoli?
Yes.
I'm sorry to interrupt. Your presentation is in the speaker mode.
Okay.
Just wanted to let you know.
Yeah. So I'm sorry. What do I need to do for you to see it properly? It's coming up as, I'm sorry, I'm not sure what. Okay. What are you seeing?
We're seeing like the black panel with all the slides, the speaker mode.
Oh, okay.
Maybe.
Let me unshare a moment.
Yeah, that's probably the most challenging part of presenting over Zoom.
And take
So
your
let
time.
me try to reshare. Is that better?
I think,
yes,
yeah, maybe we can just use this. Yeah.
Okay, okay. All right. This is I could, if I go to this is how I had it before. Is this not presenting properly for you?
No, I think the other would be better maybe, and just maximize the each screen.
Okay. Let me just go to full screen. And I will, okay. I'll go. Is this okay?
That's great.
Okay, thank you. So cancer fragmentation refers to the process by which very large DNA molecules, the chromosome, the multi-megabase lengths of DNA in chromosomes in intact cells, is reduced to very small fragments when those cells die and release their contents into the bloodstream and into circulation. We know that the DNA is cleaved into very small fragments. And this graph on the right shows a typical size distribution where the x-axis is the length of the DNA fragments in circulation, and the y-axis is the frequency of those different lengths. And what we find is that the average length of DNA in circulation is only about 179, 180 base pairs. So that you go from multi-megabase chromosome lengths of DNA that then get cleaved during the process of cell death or apoptosis, and necrosis to these very small fragments that circulate in the plasma of a patient with cancer. Now, everybody has DNA in circulation. It mostly comes from the small number of circulating white cells that may die, while they're die just through natural processes. And so, what we're trying to find in the blood of a cancer patient is evidence of DNA from the tumor cell mixed in a background of DNA from the circulating white cells. So this process of fragmentation for a long time was thought to be random, that it really, that the DNA was cleaved randomly. But what was realized is that the DNA is actually protected by being bound to the underlying nucleosomes in the chromosome. So here is a diagram of the DNA in a normal cell, and in the genome is organized into two different basic patterns that are distinct and unique to every cell type. And these are referred to as open chromatin or euchromatin, or heterochromatin or closed chromatin. And so what these areas are characterized by a complex three-dimensional structure of the DNA and the histones, the underlying protein molecules in the nucleosomes, by the methylation profile of the DNA at these sites, and also the underlying acetylation of the histone proteins themselves. And this process is very important in regulating gene expression. So for a gene to be expressed, it has to be in a region of the genome that is in open chromatin, so that there's actually physically room for the RNA transcription complex to bind to the template DNA and transcribe that into RNA. And then the DNA has to be typically unmethylated. The histones are acetylated. I'm doing this right. The DNA is unmethylated. The histones are acetylated. And so this is available for transcription. And then the DNA in the closed chromatin, both through methylation and acetylation and physical structure, is not available for transcription. And so what was realized is that this same structure that is important for regulating gene expression also is involved in determining the fragmentation profiles of the DNA. And that the DNA that is less tightly bound to the nucleosomes can be cleaved by the caspases during apoptosis, or cleaved by the endonucleases, the cytoplasmic and circulating endonucleases. And so in essence, the key point is that the fragmentation is not random, and it reflects the basal chromatin organization, which is very tightly regulated in the cell of origin of the DNA. So because each cell has a different pattern of gene expression, then that is reflected by a unique pattern of chromatin organization, and then that is reflected in the fragments we find in the blood. So why is fragmentation advantage? We've known, for a long time about canonical cancer mutations. We've known about differences in methylation for a long time, but we believe that fragmentation has an advantage over both of these approaches because there are so many different fragmentation differences between a cancer cell and a normal cell. So a typical cancer cell may have tens or hundreds of mutations, and these have to be found by targeted and deep sequencing. This is an expensive, complicated process that is difficult to do clinically, inexpensively. When we look at methylation, there are probably thousands of methylation differences across the genome. And again, these can be found with less sequencing, but also with a more complicated sequencing process. But with fragmentation, there are so many of these differences that they can be found relatively easily with low coverage sequencing and relatively simple analytical approaches. So the underlying idea is that cell-free DNA is isolated from the plasma in our test, we use 1 ml of plasma, which is around 20% of what it would be needed for a mutation-based test. And we generate what we call these fragmentomes, or these fragment profiles across the autosomal genome from chromosome 1 to 22. So here, basically what we do is we do whole genome sequencing. We then map those sequences back to 500 adjacent bins across the genome, essentially covering the genome in consecutive order from the top of chromosome 1 to the bottom of chromosome 22 in these 5 megabase fragments, and then explore differences in fragment sizes in each of those bins. And if you recall, going back to here, because of the different patterns of open and closed chromatin, the DNA will be cleaved differently in the cancer cells compared to the white cells. And so we will start to see variability in the fragment ratios in each of these short regions of the genome. And so what we have found is that in a patient without cancer, that there is very, very little variation in this fragment profile. It is extremely consistent, and it changes very little with age or with gender or other diseases, not including cancer. So common conditions of cardiovascular disease or autoimmune disease or inflammatory conditions don't appear to change this fragment profile very much. It requires the presence of a cancer to do so. And this fragmentation profiles can be used to interpret all of the canonical molecular changes that occur in a cancer cell, from gene amplification to chromosomal aneuploidy to chromosomal deletions and focus deletions to mitochondrial sequences and mutational effects, all affect this fragment profile. And Dr. Kim will take you through this approach when it's applied to liver cancer in her subsequent presentation. So the Delphi test involves a blood sample that is collected and processed to isolate the plasma, and then a whole genome library is made and then sequenced to low coverage to generate these fragments, and then run through a bioinformatics pipeline to generate these molecular profiles of healthy people and cancer. We then train a machine learning program to be able to identify the differences in these fragment profiles, to identify the gradual infiltration of cancer, evidence of cancer in early stage through late stage cancers by looking at the DNA in the plasma, and we do not need to require DNA from the tumor. So this is a tumor uninformed approach that does not require biopsies and sequencing of the tumor. Once we've identified the cancer, we're also basically developing the technology to be able to identify the source of the cancer. Because again, going back to the same idea that each cell type has a different profile to allow differential gene expression, this can also be exploited to ask the question is, if we find a difference between the cancer and the normal, then we can ask the question, from what cell type does this cancer likely arise? This data was first published in a paper by Stephen Cristiano and colleagues in 2019. About a little over 3 years ago now. And here you can see on these, we show the fragmentation profile in a group of 200 healthy individuals, and then individuals with a variety of different cancers: bile duct, breast, colorectal, gastric, lung, ovarian, and pancreatic. And so what is important to note is in this line along the top in black, these are the healthy controls. These are people not thought to have cancer and with no evidence of any type of cancer. And they generate a very consistent profile, which we have seen very, very consistently now in thousands of individuals without cancer. This looks like a single line, But in fact, this is 215 lines drawn on top of it, drawn on top of each other. And there's very, very little blurring, showing you how consistent this profile is, in individuals without cancer. And this profile is driven by the fragmentation of DNA from the white blood cells. When you begin to look at cancers, you start to see these autosomal genome-wide profiles from chromosome 1 to 22 begin to vary a lot. And so, colorectal in particular, for example, very varied patterns. You can see evidence of chromosomal aneuploidy here. You can see evidence of chromosomal regional deletions and a lot of other changes. But you can just see by eye that these look very, very different to the patients without cancer. And of course, each of the cancers, the profiles look subtly different. They're different from the white cells, but the cancers are also different from each other and can be helped. We can use this information to try to identify the source of the cancer. The performance of this test was originally described in Stephen Cristiano's paper. And at 95% specificity, the Delphi test detected 79% of localized cancers and 82% of metastatic cancers. And you can see here in this area under the curve of a ROC curve analysis, you can see here the specificity and sensitivity, that the Delphi score is the top line in dark blue. If you just look at chromosomal aneuploidy, that's the light blue, and then levels of mitochondrial DNA is a very crude test in comparison. And you can see the performance of the Delphi test has an AUC of 94%. So this was really across those 7 different cancers, all of which are at different stages mixed up amongst the group. So obviously the goal here is now this was the starting point to look at different types of cancers in more detail. And Dr. Kim will present the data on a recently analyzed study in liver cancer that was published late last year by Foda et al. On the use of this methodology for the detection of liver cancer. So we have published these data in three publications. The original methodology is published in the paper by Stephen Cristiano and colleagues in a publication in Nature. This was followed on by a publication by Dimitrios Mathios and colleagues showing application of this test in lung cancer. And then most recently, the publication on liver cancer. So I'm going to stop here. I hope that gives you a sort of technological background to the fragmentation test and allow Dr. Kim to take on and then describe the application of this new type of test in liver cancer.
Thank you, Dr. Dragapoli. That was excellent. I always learn from you. So can I just go ahead then share my slide?
Yes, please go ahead, Amy, and then we will answer the question in the discussion time. Yeah.
Excellent. And we will see if my sharing will work. It's the same problem as before, correct?
Yeah, maybe you change it to slideshow, Amy, and see whether it works. Yeah, there you go.
Excellent. All right, thank you so much. And first, thank you for the invitation to talk about our work. And in the next 15 or 20 minutes, I wanted to focus more on the clinical perspective of using, cfDNA fragmentomes, Delphi that we just heard about, and what led us to investigate this in HCC as screening. These are my disclosures. So in terms of the outline, I wanted to briefly just go over the burden of HCC. I'm sure many of the audience here are already familiar with this. The current recommendation that is present for screening and the tests that are available. And we'll discuss a little more in the role of liquid biopsy, specifically the Delphi test, and the additional potential role for liquid biopsy in HCC. So I think it does, bear mentioning how important this topic is. Liver cancer, we know, is one of the leading cancer worldwide. It is the 6th most common, and it is the 4th leading cause of death in cancer. But what we don't always talk about is the fact that among all the top cancers that we see, the death rates from the cancers are downtrending, except that in liver cancer, it continues to rise. That's something that is unique in all the solid GI tumors. The only tumor that we see that exceeds the increase in terms of the death rate is the thyroid cancer. Sorry, I'm having a little problem moving my slides, but I think we know that the sleep increase is very noticeable in Vietnam. I'm talking to the audience who are probably more familiar with this. I was surprised as I was preparing the talk at the steep increase that is in Vietnam, that over the last 20 years, seems like there's been almost a quadruple fold of liver cancers that are diagnosed in Vietnam in both male and female. It really highlights the urgent need to have a better prevention and treatment strategies for HCC worldwide. What's also important to note is the crucial aspect of the late diagnosis in HCC. Here, this is based on European population. There's a cohort of 600 patients where they follow to see the natural progression of HCC and stratified by different stages of HCC. So from the top being the very top 2 lines being the early stages of liver cancer, staged by the Barcelona criteria, and the bottom 3 lines reflect the intermediate to late stage. And you can see that at year 1, there's a huge gap between the blue and green versus the rest of the lines. What this means is that there's a big difference in terms of the 1-year survival between the intermediate versus the early. And unfortunately, these bottom lines reflect 70% of the HCC that's diagnosed currently. So not only does this mean that earlier detection is key in improving survival, we still have room and much more work to do in terms of improving the treatment for patients who are presenting with HCC. So given the risks of HCC, we do have a specific screening recommendations worldwide by multiple societies, including Asia, Europe, and America, to really focus on at-risk population. One thing to note for HCC compared to other cancers that I've mentioned before is that HCC doesn't occur commonly, or the whole population does not need to be screened for HCC. We have specific at-risk populations who have been identified to have 3 to 4% of HCC risk annually. So those are the patients with viral hepatitis, specifically hepatitis B, and those with cirrhosis. So current guidelines to screen this population really hasn't changed in the last 10 years. Most commonly, the recommendation would be the ultrasound, and some of the societies actually add AFP, the alpha-fetoprotein, on top of the ultrasound to screen them. What is limiting is that these tests, although that is, it has been validated to improve survival by having early detection, they're still challenged by low sensitivity. The table here was is to just reflect that, AFP, while it's quite specific, the sensitivity is really merely 50% at, overall. Ultrasound sensitivity maybe 92%, but what we're now seeing is that with the increasing non-fatty liver, non-alcoholic fatty liver disease and obesity, the sensitivity is also challenged with challenge to detect small cancers. In the last probably 10 years and over the last few years, we've been incorporating additional markers. These are two proteins, that's carboxyprothrombin, as well as the AFP-L3, which have been shown to be a little bit more specific and can be more sensitive in specific populations. But again, they have not really shown to be that much better than AFP. So many of the guidelines do not really routinely recommend this. What we do know is that when we add these panels together, that it can expand the sensitivity, can increase the sensitivity. So lately, we've been incorporating Galit score. The G and the A stand for gender and age. So it incorporates gender, age. L stands for the AFP-L3, and the DCP is reflected of the D is standing for the DCP, to increase the sensitivity and the specificity of screening for HCC. Now, this is not routinely used clinically, but to improve what we have thus far. We also have more smaller, study data for abbreviated MRI to see if we can improve the imaging aspect of screening for HCC as well. But one thing that, as Dr. Dracopoli also alluded to, over the last 10 years, we've been focused also on detecting more of the genetic materials from blood. There's been a lot of focus in circulating tumor DNA, cell-free DNA, as we've been talking about. Some of the other genetic materials that we can find would be exosomes from extracellular vesicles and biological fluids, including blood, and also from bile, saliva, and urine. And these have been targeted areas to see how we can improve the detection of cancer, and actually to further along the understanding of the disease of liver cancer. So in the same line, over the last 10 years, we've seen studies using liquid biopsy, specifically circulating tumor DNA in HCC. I've just, listed here some of the early studies that have shown some promising data in the past. Dating back to 2015, there was a study looking at small population, but looking at methylation markers to see how that could be utilized for screening. And since then, we've had numerous publications looking at, methylation as HCC, biomarker. Our colleagues at Hopkins have published CancerSeq, which is a pan-cancer screening test in which they look at multiple mutations for all cancers, plus proteins to increase the sensitivity as well. And that was really a landmark in looking into the utility of circulating tumor DNA as a overall cancer screening test. This was followed by another paper that came from Asia, where they looked specifically into hepatitis B. This is from the Q et al., where they looked at specifically TERT, P53, axin 1, and beta-catenin mutations, plus AFP and DCP. So the reason why there's always a protein that's involved in these panels is that, like what we just heard, it is very challenging to just depend on mutation as a screening test. As it was described earlier, only a small fraction of this the cell-free DNA contains circulating tumor DNA, and on top of that, not all circulating tumor DNA contain mutations. So specifically for HCC, after, TERT and P53 mutations, in which the frequency is ranging from 20 to 40%, all the other mutations in HCCs are mostly below 10%. So the reason we were interested in DNA fragments, ctDNA fragmentomes, for the specific reason, and to see if, because it seems to have a clear advantage over other ctDNA tests. So in this study, we wanted to first test the feasibility and then check the performance of the ctDNA fragmentome analysis. So we collected 75 cases of HCC from our center and compared it against two types of controls. And number one would be the at-risk population that included cirrhosis or chronic hepatitis B. We also included chronic hepatitis C with evidence of fibrosis in this control. And then we had 290 patients, 93 patients who were healthy to compare as well. Initially, we started this as a small study to look at the feasibility, but the performance was excellent. So we moved on very quickly to a validation cohort. So in this study, we had the validation from a cohort from Hong Kong, in which we had 90 patients with HCC, almost all of them with very early disease. And then the non-cancer patients, in which more than 75% of them were at risk with chronic hepatitis B or cirrhosis. And this is something that now we're familiar with. This is a fragmentation profile of the patients in each group. And as we just heard, similar to the previous studies in Delphi, the healthy controls had very tightly correlated fragmentation profile. So just to remind everyone, the y-axis is the ratio of the short fragment to long fragments, and this is throughout all the positions of the genome. And here at the bottom row, we have the cancer patients with HCC, and you can see the marked heterogeneity in this fragmentation profile, as we just learned, and this is consistent with all the other cancer types that they've looked into in the past. What was also interesting is that in the cirrhotic group, you can see that with disease, we do see slightly more variation in the fragmentation profile, but it's still distinguishable from the cancer cohort. So we used the machine learning approach then to determine if the changes in cfDNA fragmentomes can be distinguished, can distinguish HCC from controls. And from that machine learning process, the Delphi score is developed, and the Delphi score was clearly distinguishing the non-cancer to the different stages of HCC in our cohort. And when we compare to the at-risk population, although you do see the increased variability, it still distinguishes even the early stage HCC from our at-risk population. And this is a subset analysis, again, kind of looking at the area under the rock to see the performance of Delphi, and then with the validation set. So across all stages, so if you focus on the orange curve, which I think is the most useful comparison, looking at the at risk, the error curve on average is at 0.9. And compared to the healthy control, which were almost at 100, the area being almost close to 1. And what was also promising was that validation set really performed excellently with the error curve close to 0.97 for compared to the healthy controls, and 0.9 compared to the at-risk population. And one other thing to really note is in continuation with the previous talk, these fragmentum profiles are not just random. They're really capturing the chromatin characteristics, which I didn't really put in this slide, and also the genomic characteristics of HCC. One of the unique discoveries from this paper is that our team analyzed almost 6,000 chromatin immunoprecipitation sequencing experiments from a large database, and kind of characterized each transcription factor to have to average out and analyze it for each sample. So what we're seeing here is that for each transcription factor in our samples have a unique single metric, and we identified the top 9 transcription factor that had the highest variability compared to the healthy controls or non-cancer controls. So the red line here would be the HCC compared to the non-cancer controls, and you see the big difference between the non-cancer. On our right panel, these are the transcription factors that really do not have a big distinguishable difference between the HCC and non-cancer. And what was very interesting is that all of these 9, the analysis of the transcription factors were involved in the pathways in the development of liver cancer. And compared to AFP, specifically in our cohort, its ctDNA fragmentums really performed better. In this case, the AFP detected 50% of the HCC cases, which is kind of in line with the literature, and only 33% of those were in early stages. Among the patients who had what we would be labeling as negative AFP, with AFP value less than 20 nanogram per mil, Delphi detected 83% of the cases. So I think we now know the robust performance of ctDNA fragmentums in HCC. We're looking into what are the other utilities that of liquid biopsy ctDNA that we can use in HCC. Now we're focusing more specifically on disease monitoring, not only in terms of treatment response, but also in disease surveillance after curative therapy. With HCC, even after resection and liver transplantation, cancer recurrence can happen, and we don't have good tools to kind of predict this or risk stratify them. So we're looking into ways to use Delphi as ctDNA fragmentome technique to see if we can help identifying these patients early. The fragmentomes will probably be an additional tool to assess tumor burden in addition to imaging. I don't think that just liquid biopsy will replace everything in terms of our management of liver cancer, but it'll be a very, very valuable additional tool to really accurately assess how much tumor there is that we can detect radiographically. And as we just saw the correlation to the genomics of the tumor itself, it is going to be a very important tool to characterize the HCC without additional tissue. Thank you.
Thank you, Nick and Amy. I think great talks, and we will have a very interesting discussion. To warm up the discussion part, now you can see in the QA part, there are 3 questions from one audience. There are several answers that I think we can find in your presentation, Amy. She asked about the factor associated with characteristic of fragmentation profiles like age, gender, or ethnicities. And she also asked about the AI techniques used to classify cancer and non-cancer patients and among the different types of cancer. Maybe this question is for Nick. And the specificity of Delphi score. And she also asked about a very practical issue, that is the test cost comparing to ultrasound and other biomarker tests. So I think very interesting question to warm up our discussions.
No, thank you for the questions. So I didn't add the slide, but Delphi score was analyzed specifically to age, gender, and the ethnicity. I'll go into a little bit further, but there was no correlation with age and gender. So it's kind of interesting with the Gallup score, including age and gender to expand the sensitivity. But in our paper, we actually specifically mentioned the Delphi score among the ages and gender. The ethnicity, there was a small difference between Asian population. I do have to go back to the specifics, and we do mention this, but not enough to really separate the population. So there seems to be, I think it was related to, I think with the Asian population, it performed better. And I can look it up while Dr. Dracopoli is looking at from our studies, but not significant enough for us to think that this is specific to a specific ethnicity.
Amy, for this one, I want to add on one more comment. Is it due to the different etiologies like the viral hepatitis B, C, or it is only ethnicity?
It was just that it was the ethnicity, and I will go back, but when we looked specifically for non-alcoholic hepatitis as well from this group, there was no significant difference between viral hepatitis and the non-alcoholic hepatitis.
Yes, so could you please give me a very short time to interpret into Vietnamese, because maybe some of the audience will not understand very clearly. Có một câu hỏi của một bạn bác sĩ, đó là có yếu tố nào liên quan đến cái xét nghiệm này như là tuổi, giới, chủng tộc không? Thì thật ra là trong slide của chị Amy cũng có một cái slide mà về validation ý, thì cũng cho thấy rất rõ là không có cái sự khác biệt về tuổi, về giới. Thế còn về chủng tộc thì cũng có một sự khác biệt một chút giữa nhóm chủng tộc châu Á với cả nhóm chủng tộc châu Âu và Mỹ, nhưng mà cái sự khác biệt thì nó cũng chưa có ý nghĩa thống kê. Và thật ra thì hồi nãy tôi cũng có hỏi thêm một chút, đó là liệu nó có liên quan đến cái nguyên nhân của ung thư gan không? Bởi vì nhóm nguyên nhân về viêm gan virus hoặc là các nhóm nguyên nhân không viêm gan virus. Nhưng mà hiện tại thì trong cái nghiên cứu đó thì cũng không có thấy sự khác biệt về nguyên nhân. Ở đây thì anh Trung cũng có muốn tham luận thêm ạ. Dạ, xin mời anh Trung ạ.
Okay, I think that the cleavage pattern of chromatin, or how chromatin is shared into a fragment, it also depends on the accessibility of the chromatin. I mean, okay, either the chromatin is open or it's closed. It will be influenced to the fragmentation. Therefore, the differentiation or the transformation level of the cancer cell would also contribute to the fragmentation level. That would raise a question. That would automatically raise a question. For instance, how we can use this technology to kind of to classify the cancer stage, because cancer stage somehow indirectly relate to cell type differentiations. The cell type differentiation, of course, influence to the DNA or chromatin fragmentation, and that's I could not answer by myself, and this will be for sure will be raised by technical person in the real clinical practice. Okay.
Yeah, I think that's a great question, and I think you're absolutely right. The strength of the signal is really going to be driven by a number of features around the total tumor burden, the stage of the cancer, the proliferative nature of the cancer. And it's certainly true that the signal is much stronger in advanced cancers than it is in earlier cancers. We still don't know how early we could go. But I think it is fair to say that the ability to differentiate if you think about a very early cancer, it's small, so it won't be necrotic, so there will be no cells dying through necrosis. The tumor, the mutational burden will still be relatively low at that stage, so the cells will not be apoptotic. And it's also unlikely that those very early cancers have been recognized by the immune system yet. So they're not subject to immune-mediated, T-cell mediated or destruction. So there is a point in very early cancer where these very small lesions will be releasing very little material into circulation. So we don't know how early we can go. The advantage that we have with fragmentation, though, is that there are literally millions of differences based on what you spoke about in terms of the open and chromatin patterns, that we have a possibility of being able to find these early stage diseases just based on the number of fragmentation differences are so much bigger, more than they are with methylation or mutation. So we have evidence in lung cancer and now in liver cancer that we are able to detect early stage cancers. The ultimate sensitivity still has to be determined. And that where I think is where a lot of the future work will go. Some of it will be driven by improvements in the algorithm, and be able to differentiate cancer and non-cancers. We get better at understanding the biology a little better. I think there are going to be opportunities to find more genomic features and integrate methylation and fragmentation into similar assays that will help improve that. But the advantage we still have is with fragmentation, we generate about 40 to 50 billion reads of these short fragments, average, 150 to 300 base pairs. So there is a lot of additional genomic information in there that we're sort of teasing our way through, trying to find, things that are more informative. We and others, for example, have worked on looking at the end sequences of the fragments, which are relating to how the DNA is cleaved. And there are clearly, specific patterns there that may emerge, to further help us define, the source of the cell source, and then that will help us improve the ability to differentiate between the white cell DNA-derived DNA and the cancer-derived DNA. So this is an area of very active investigation, trying to push the sensitivity ever lower while maintaining a level of specificity that is clinically relevant. We're not there yet completely, but it's an area we can see will improve very quickly over time. I think there was one other question about the pricing of the test. Is we don't know what the commercial price of the test in the US will be where we launch first, but the test is going to be in the low hundreds of dollars, maybe even in the hundreds of dollar range. Hopefully it will get lower as we go internationally and bring the test out more broadly. It would be able to, we'll be able to drop below that, but it is probably only somewhere around 10 to 15% of the cost of a mutation-based test.
And also just to emphasize that, like what Nick just said, in the early stages, like I won't share the slides again, but when you look at the BCLC0, so those are lesions that are less than 2 centimeters in just one. So that's a very, very early stage cancer. And even though the Delphi score was lower than the most metastatic disease, it was enough of fragmentation to distinguish that even from the cirrhotic patients. So while that there is room to improve, to move that further, in comparison with some of the other tests that we've seen, it's enough to at least find those really, really small cancers. And as someone who also sees patients to find these small cancers, I think the performance was very, very good, just from a peripheral blood test.
Yes, please have a short break here to interpret for the participants, because we have received many questions that please translate a little into Vietnamese for them also. Anh Trung ơi, vấn đề này nó cũng hơi khó nên anh có thể wrap up lại những cái phần mà bác Nick vừa nói về mặt kỹ thuật được không ạ?
Tức là như thế này. Sorry, can I speak Vietnamese for my colleagues? It's okay?
Yes, please. Because many participants send message to us to ask that, please translate into Vietnamese for a while.
Tức là câu hỏi của anh ấy, anh có đặt câu hỏi rằng là cái phổ cắt của các cái đoạn gãy DNA như thế này ấy, thì đã hiển nhiên là nó phụ thuộc vào cái cấu trúc của chromatin, cấu trúc của nhiễm sắc thể. Mà cấu trúc của nhiễm sắc thể ấy, thì là các cái mức độ biệt hóa khác nhau, thì cái nhân bào của nó sẽ có cấu trúc khác nhau. Đấy, cái nhân bào ấy thì tự nhiên nó mới nảy sinh ra một câu hỏi rằng là rõ ràng là cái kỹ thuật này phải xử lý được cái việc mà vì là các cái mức độ biệt hóa khác nhau của tế bào thì nhân bào nó sẽ khác nhau. Vậy vì các mức độ biệt hóa đấy nó phải liên quan, nó hiển nhiên nó phải trả lời câu hỏi của mức độ biệt hóa. Thì ông ấy có nói rằng là cái chỗ đấy thì là còn rất nhiều cái mà cho ông nói rất là dài, nhưng mà ông ấy đồng ý với câu hỏi đấy. Đấy là cái điểm hóc của cái công nghệ này. Hiện giờ thì công nghệ này nó đang khó chỗ đấy, nhưng mà đột nhiên khi mà anh nghe cái đấy thì tự nhiên nó nảy sinh ra một câu hỏi khác ở trong anh, thì anh muốn hỏi tác giả một câu hỏi nữa nhé. Thì nó sẽ rõ ngay bây giờ, em nghe câu hỏi nó sẽ rõ ngay bây giờ thôi, mà nó sẽ dần dần đến, chắc là họ phải làm thêm một số thí nghiệm theo cái ý nghĩ của anh thì nó sẽ ra thôi. Can I because after your explanation, yeah, and also after hearing clearly your presentation, it raised up in my mind another question regarding to your technology. This is just to make your technology more clear for the audience. Can I ask it?
Yeah, please do.
Yeah, because you mentioned there's a slide you mentioned about the enrichment of transcription factor within the fragmented DNA, the free fragmented DNA. Is that true?
Yes. So, Amy,
Yeah.
do you want to answer that one, or?
Yeah.
Yes, sorry. Would you mind repeating the question?
Oh, because there's a slide where you describe the enrichment of some transcription factor within the fragmented DNA. Yeah.
Yes.
So I don't remember exactly, but there are 9 transcription factors. It's very, very enriched, and there are another 9 transcription factors. It's very, very poor. It's not poor enriched. And my question is that because the differentiation or different states of cell type differentiation always are regulated by specific transcription factor. I don't know either those transcription factors, some specific for special cell type differentiation states. If it's true, then of course you can somehow normalize to, or you related this transcription factor profile and this DNA profile to the specific, to the different states of the carcinogenesis of the patient. Who do you think this theory is reality? You understand my question?
Yeah. So the 9
different states of cell type differentiation is always regulated by different.
Absolutely right.
Master regulator or master transcription factor. That's written in the textbook. And in your slide, there's some transcription factor that you can fish out, which is very, very specific for liver cancer. And I wonder if they can also indirectly answer the stage of the differentiation of the cell or differentiation.
Yeah. And that's actually
somehow it indirectly answer my previous question about the status of the of your technology, for instance.
Yeah. And if I understand, yes, I think we're talking about the same thing. And Nick, you can chime in as well. But that's exactly what we're, at least from this current step is to see how much we can, glean from this technology to specifically characterize HCC. So yes, the transcript, the genes enrichment shows that we can learn more information, beyond just the fragment size. And what we're trying to do right now is how much of the subset analysis we can do, actually, like the transcription profiling of the cancer, because like you said, there's some that have high turnover, more aggressive phenotypes. We already know specific subtypes of HCC,
yes.
but we don't use it. because it's hard for us to actually get that information when it's timely. So what I mean by that is we don't do routine biopsies, and biopsies are not comprehensive genomic analysis of the HCC because they're so small. So we're actually trying to dive in further into what you just talked about to characterize the HCC.
Okay.
Yeah, I was just going to add that I think this. I think you're thinking in many of the same ways that we are around exploiting information in the genome. I mean, with the transcription factor binding site work that was initially published in the Mathios paper in lung cancer, but can also be applied with different, as Amy said, was discussed in different genes and transcription factors in liver cancer. It also comes down to differential protection of the DNA from cleavage, and that those genes that are highly expressed in the cell of origin are likely to have the transcription factor binding complex bound to the DNA. That's going to give a slightly altered fragmentation profile and coverage across those particular sites. And so in the lung cancer study, for example, we looked at the ASCL1 family of transcription factors. And you can see the differences because there are not just one binding site, but literally hundreds or thousands of these transcription factor binding sites across the genome. So even in low coverage sequence, we can see these differences that are cell specific. This is what Amy reported again in looking at different transcription factors in liver cancer. So we're hoping to try to use this information to get further ability to identify or differentiate DNA derived from the white cells where a certain gene or certain set of transcription factors are not being used to drive gene expression compared to a cancer cell where they would be. And this will further, again, help us find the noise of the signal of the cancer against the noise in the background genomic DNA. And we think this potential has great promise.
Chắc là đoạn này thì cũng hiện tại thì ban tổ chức cũng có nhận được rất nhiều những comment với các câu hỏi của các đồng nghiệp, là cái phần này cũng tương đối khó hiểu, cho nên là em cũng xin phép là có thể là tóm tắt lại ý này một chút, còn nếu như thiếu sót gì thì chắc là nhờ anh Trung bổ sung thêm. Thì từ nãy đến giờ các chuyên gia của chúng ta thảo luận rất nhiều. Câu hỏi thì cũng xoay quanh vấn đề mà anh Trung cũng có đề cập, nghĩa là liệu cái công nghệ này có thể giúp cho chúng ta phát hiện được ung thư nhưng mà ở các giai đoạn khác nhau với mức độ biệt hóa khác nhau hay không. Thì đấy cũng là một câu hỏi mà khi mà chúng ta nghe các cái bài báo cáo ngày hôm nay thì chắc các quý đồng nghiệp cũng có chung cái thắc mắc như vậy, và cũng có một quý đồng nghiệp đã hỏi cái câu hỏi tương tự ở trong chat box. Thế thì hiện giờ ấy, thì rõ ràng là cái việc này nó cũng vẫn đang tiếp tục được nghiên cứu, nhưng mà cũng có một số những cái hướng tiềm năng. Ví dụ như là trong bài báo cáo của chị Amy thì cũng có một cái slide nói về các cái yếu tố phiên mã mà được bộc lộ rất là nhiều, thì có thể đấy là một cái cách giải thích cái mối liên quan giữa cái con đường dẫn đến ung thư, cũng như là tại sao mà ở một số bệnh nhân thì cái biểu hiện gen như vậy thì có các cái yếu tố phiên mã biểu hiện như vậy, thì liệu nó có liên quan đến cái mức độ biệt hóa hay không. Nhưng mà chị Amy thì cũng có giải thích là thật ra thì ví dụ như nó cũng có cái khó, họ rất là khó để mà chứng minh được cái này, bởi vì là ở Mỹ thì cái việc mà lấy cái mảnh sinh thiết ấy không có được thực hiện nhiều, và bản thân cái mảnh sinh thiết ấy thì nó cũng có cái kích thước nhỏ, thì nó sẽ không đại diện để mà chứng minh được như vậy. Tuy nhiên thì nếu như mà nhìn ở dưới góc độ của cái người làm kỹ thuật ấy, thì như bác Nick có chia sẻ ấy, thì đây vẫn là một cái hướng rất tiềm năng, bởi vì nó có thể kết nối được các cái thông tin giữa cái việc là selfie DNA kết quả như vậy này, các cái con đường tín hiệu như vậy này, và liệu thì đến bao giờ thì chúng ta có thể chẩn đoán được bệnh nhân. Nhưng mà cái câu hỏi là cái mức độ sớm đến như thế nào, cái xét nghiệm này độ nhạy phát hiện được sớm như thế nào, thì nó vẫn là một cái câu hỏi mà chúng ta bỏ ngỏ. Nhưng mà dựa trên cái dữ liệu mà chị Amy có nói ấy, thì chị Amy cũng có nhấn mạnh là mặc dù là cái nghiên cứu của họ thì chưa có quá nhiều bệnh nhân, nhưng rõ ràng là đối với cái nhóm đối tượng mà BCLC giai đoạn 0 ấy, là cái nhóm đối tượng mà u rất là nhỏ ấy, thì vẫn thấy cái nồng độ cái chỉ số Delphi score ấy, nó có cái khác biệt với cái nhóm bệnh nhân xơ gan. Cho nên là rất hy vọng là đây có thể trở thành, nó không thể thay thế các công cụ mà chúng ta đang có, nhưng mà rõ ràng là rất hy vọng nó có thể là một cái công cụ hỗ trợ. Thế thì nhân cái câu hỏi này thì có lẽ chúng ta sẽ move một chút sang khía cạnh lâm sàng hơn, bởi vì ở đây tôi có nhìn thấy có câu hỏi của một quý đồng nghiệp liên quan đến câu chuyện, có 2 câu hỏi rất tương tự nhau. Đó là câu hỏi liên quan đến câu chuyện là so với siêu âm, so với các dấu ấn sinh học khác thì cái xét nghiệm, cái công nghệ này có gì ưu điểm, cũng như là cái khả năng mà ứng dụng ở các nước mà đang phát triển như thế nào. Thank you, Nick and Amy. So now we would like to move a little further in the clinical application. So what do you think about the application of this technology in the low and middle income countries? And for clarify this question, I think maybe like at which kind of patient will you indicate for this test? Like if AFP negative, is it a indication for this additional tools?
Sure. I think I think one of the things that we do see is the wide application for this, fragmental study for all at-risk population. I know that in Asia, specifically also in Vietnam, the prevalence of hepatitis B is quite high. And I think particularly it was promising that in our validation study, where predominantly they were from Hong Kong, with more than half of them having hepatitis B. So we see that it's going to work well. Now, I do think that the screening guidelines, and maybe Dr. Dow can help in terms of whether the recommendations from this society, from the government is different. But it would be a blood test that can go along with chronic hepatitis B patients who are, number one, getting screened for Hep B. And in one sense, at this point, the technology to detect cancer is just as, we do need more studies, but it's just as good as detecting hepatitis B virus. So then I would recommend definitely to just incorporate that on the same blood test in the same vial that you get. And then, obviously the incidence of, fatty liver is increasing throughout. So, those, I do think that the screening recommendations will change in the next decade. But at this point, those with, advanced liver fibrosis, with, fatty liver disease, or all kinds of the chronic advanced liver disease should be screened for HCC. And, to emphasize the point that so far, all the mutation-based tests could not be done, in low-income countries. And also, I think we scratched our heads in terms of how to use this clinically, even in the US. But given the lower cost, I think it makes it more promising and feasible.
I think you're right, Amy. So I have no further comment.
Yeah, so I don't know if I would think that the screening recommendations are the same worldwide, but I just wanted to make sure if something was different.
Very similar.
Thank you, Amy, because I think in many countries, but especially in developing countries, the cost effectiveness is one thing that all the clinicians must consider a lot, especially when we try to explain to patients. So, for example, in Vietnam now, in case AFT negative, maybe as you also mentioned, now we use more and more GALAS score, and I think it is a very useful tool. With AFPL3 and PICA2, it is easier to detect more liver cancer, but now the cost is one barrier for Delphi score. And the second thing is, as you said, the question that is it useful to screen for the all high-risk patients, I think will be a debating issue, because it requires, as you said, it requires a local data, and it requires maybe head-to-head trial to compare the different methods of screening. But very promising, I think so.
Yeah, no, that's a good point. I didn't think about going to the specifics of that. Yeah, but absolutely. Then the first population that you need to target are those with low AFP. Now, that will add the challenge, right? To because then we will have 2-tier screening, AFP, and then you will have to identify those with AFP and then do it. And that there isn't the cost that is hidden in terms of making that happen. And what we see is, unfortunately, in the US, the adherence to screening is, barely above 30%. And this is in the US, where we have a lot of healthcare centers around. Of course, in rural countries, it's lower. The counties and areas within the US is lower. So that's one thing to see. Like, is it really cost effective to target AFP negative, or is it actually just better to test them all?
Yeah. Nick, could I ask again, because I think I missed that information. What is the cost of the test at this time?
The test is still a research test. We have not commercialized it in the US yet, but it is very much, we are very aware of cost. I know that in order for a screening test to be successful and widely applied in high-risk groups, the test has to be very inexpensive. So I can't say what the ultimate cost would be, but I would say that the cost of doing the test is somewhere around 10 or 15% of the cost of doing a mutation-based test. So we should be able to, our goal is to deliver a product that will be at a price that is acceptable for the different markets in the US and Europe and countries in the developing world. So it would be acceptable and practical to incorporate into a global use. So we're doing everything we can to drive the cost of the test as low as we can. And it will absolutely be much, much, much less expensive than the mutational or methylation-based tests.
Ở đây thì câu hỏi chúng ta sẽ sang phần hơi có chút lâm sàng một chút, đó là chúng ta hỏi về cái khả năng ứng dụng của test này, đặc biệt là có một câu hỏi liên quan đến việc là ở các nước mà đang phát triển thì như thế nào, cũng như là câu chuyện mà chúng ta so sánh với các cái phương pháp tiếp cận sàng lọc hoặc tầm soát ung thư gan khác. Thì hai diễn giả của chúng ta cũng có những câu trả lời rất là hay, ví dụ như là cách tiếp cận, liệu chúng ta có nên tiếp cận ở cái nhóm mà đơn thuần alpha FP âm tính, hay là chúng ta sẽ tiếp cận ở tất cả các cái nhóm đối tượng nguy cơ cao. Thì ví dụ như là chị Amy có nói là ở bên Mỹ thì hiện giờ đang tiếp cận theo cái hướng là tất cả những bệnh nhân mà có yếu tố nguy cơ cao, và đặc biệt là cái nghiên cứu mà validation mà làm tại Hồng Kông ấy thì chủ yếu ở trên đối tượng bệnh nhân viêm gan B, thì thấy kết quả rất là tốt khi mà có thể phát hiện, và nó cũng có sự khác biệt rất là rõ đối với cái nhóm bệnh nhân mà xơ gan hoặc là viêm gan B mạn. Và chị cũng hy vọng là ở Việt Nam, ở châu Á thì chúng ta cũng có thể có thêm các cái nghiên cứu mà để đánh giá như vậy. Tuy nhiên thì đúng là cái vấn đề về mặt chi phí thì nó cũng sẽ là một cái vấn đề mà chúng ta cũng phải quan tâm, cho nên là có thể tại cái khu vực của chúng ta ấy, thì cái cách tiếp cận nó sẽ hơi khác một chút. Ví dụ như alpha FP thì là một cái xét nghiệm thường quy, chi phí rẻ, thì chúng ta có thể tiếp cận bằng cách sử dụng alpha FP trước, xong sau đó thì nếu như ở những trường hợp alpha FP âm tính thì chúng ta cũng có thể suy nghĩ xem liệu có nên tích hợp cái xét nghiệm này là cái bước tiếp theo không. Và chị cũng nói là đương nhiên mặc dù hiện giờ thì các hướng dẫn trên thế giới thì cũng chưa có đưa cái này vào, nhưng mà chắc chắn là trong tương lai thì cũng sẽ có nhiều sự thay đổi. Những cái sự thay đổi liên quan đến ứng dụng các cái dấu ấn sinh học trong tầm soát sàng lọc ung thư sớm, thì cũng rất hy vọng là trong tương lai khi mà có những cái sự thay đổi này thì chúng ta cũng có thể tiếp cận với công nghệ này dễ dàng hơn. Còn về phần chi phí giá cả thì cũng giống như Nick chia sẻ, đó là hiện tại thì đây vẫn là một cái xét nghiệm, một cái công nghệ rất là mới, đang trong quá trình nghiên cứu, chưa có được thương mại hóa ở trên thị trường. Nhưng mà chắc là khi thương mại hóa thì cũng sẽ cố gắng hết sức để giảm tối thiểu chi phí, và chắc chắn là chi phí mà ở các khu vực ở các nước phát triển phương Tây thì so với chi phí mà ở các nước đang phát triển thì cũng sẽ phải có cái điều chỉnh để phù hợp, bởi vì là để mà phát triển được một cái kỹ thuật đặc biệt là mang cái tính tầm soát ấy, thì ở ngoài cái độ chính xác ra thì cái yếu tố về giá cả chi phí cũng là một yếu tố phải tính đến. Hiện tại thì có lẽ ở trong chat box của chúng ta sẽ chỉ còn một câu hỏi liên quan đến kỹ thuật AI. Thì không biết là có quý vị khán giả nào có muốn đặt câu hỏi thêm thì mọi người có thể tiếp tục ở trong chat box đặt câu hỏi cho các quý diễn giả của chúng ta. I think there is only one more remaining question about AI technique used to classify cancer and non-cancer patients and among different types of cancer. I think this is for Nick, right?
Yeah, sorry, could you repeat the question again?
The question is that what AI techniques you use to classify the cancer and non-cancer patients and to differentiate the different types of the cancer? What kind of AI techniques you use?
So this emerges out of the, so we generate, the fragmentation score by a machine learning evaluation of the fragment profiles. And this generates a score between 0 and 1. And then for each type of cancer, we have to basically, by looking at non-cancer controls and then at cancers at different stages, we have to set a threshold that optimizes the detection of the cancer at a desired sensitivity and, between, and where we set it a certain level of specificity, we could see if we can achieve the level of sensitivity we need. So it is around evaluating the clinical data and determining the threshold at which we will call, a patient at high risk or lower risk of cancer. So for example, in liver cancer, we would imagine if this test is used instead of AFP and ultrasound, that if you would have a positive test, that patient would then be guided into ultrasound or perhaps MRI, and I'll let Amy speak to that. In lung cancer, we're trying to basically identify patients who don't need to have a low dose CT and can wait and then come back for a further test at a future time. But we have to evaluate the cutoff for the Delphi score for each in prospective clinical studies for each different indication.
Hi Nick, but the participant raised the question very technically. She is asking about what machine learning techniques you are using. Maybe the name, like YOLO.
Yeah, I mean, I think what I could do, I'm not an expert on the details of that. It's described in the papers that we have published. So the actual detailed approaches to the machine learning are described in the publications, and we could share those links with you for you to share.
Yeah, thank you, Nick.
Yeah, I'm not a data scientist, so I don't have the details of the exact machine learning methodology.
Thank you. Yes, okay. If it is described carefully in the manuscript, so I think we can find it. Dạ vâng, cho quý đồng nghiệp mà hỏi về kỹ thuật học sâu mà kỹ thuật học máy mà được sử dụng ở trong công nghệ này thì Nick cũng có chia sẻ là chúng ta có thể theo cái đường link vào cái bài báo gốc, thì trong cái phần đối tượng phương pháp nghiên cứu thì cũng có mô tả về phần này ạ. Chắc là một chút nữa thì Nick cũng sẽ gửi lại cho ban tổ chức link của bài báo đó, thì sau đó cũng sẽ xin gửi đến các quý vị đồng nghiệp để chúng ta có thể tham khảo thêm. So I think we only have several more minutes left. Dr. Chung, would you like to wrap up something or give more comments on our presentations today?
Thank you for your invitation. I think that for me, I quite understand the technology. So I will be here for anybody who might not be able to follow the presentation. I can also kind of put an add on for you if our Vietnamese colleagues would have more wonder about this. I together with you, I can also share my knowledge about this the understanding of this technology. Okay.
Thank you, Dr. Chu. Cảm ơn các quý đồng nghiệp. Hôm nay thì chúng ta cũng đã có một buổi Liver Talk rất là hay. Chắc chắn là cũng sẽ có nhiều quý đồng nghiệp giống như tôi là cảm thấy khá là khó, chủ đề rất là khó đúng không ạ? Nhưng mà chủ đề này rất là hay và chắc chắn là trong những năm tới chúng ta sẽ còn được nghe và được cập nhật tiếp về chủ đề này. Bác sĩ Trung cũng có chia sẻ là nếu trong trường hợp mà các quý đồng nghiệp cảm thấy là cái phần chia sẻ tiếng Anh vừa rồi ở trong Liver Talk ngày hôm nay hơi khó hiểu và có các cái câu hỏi hoặc là thắc mắc liên quan đến công nghệ này thì cũng có thể liên hệ với ban tổ chức và với bác sĩ Trung. Thì bác sĩ Trung cũng sẽ rất sẵn lòng chia sẻ kiến thức cũng như là trả lời một số những cái thắc mắc có liên quan đến buổi hội thảo ngày hôm nay. Có lẽ là thay mặt ban tổ chức thì xin phép được mời anh Doãn có một vài lời phát biểu để chúng ta có thể kết thúc cái buổi Liver Talk ngày hôm nay cũng như là cảm ơn đến hai quý diễn giả với hai bài báo cáo rất là hay ngày hôm nay.
Cảm ơn Phó Giáo sư Hằng. Nick and Emmy, I'm going to speak in Vietnamese, so I hope you don't mind, and then I will wrap up in English. Thì chúng tôi cũng rất là cảm ơn sự tham gia của quý vị, đặc biệt là có sự điều phối của Phó Giáo sư Đào Việt Hằng và tiến sĩ bác sĩ Trung. Thì chúng tôi cũng mong muốn mang lại những cái thông tin và cái ứng dụng tiềm năng trong cái việc chẩn đoán, điều trị và theo dõi trong khi điều trị ung thư gan và cái phần này thì chúng tôi thật sự mong muốn là chia sẻ lại những cái kỹ thuật cũng như kinh nghiệm từ Johns Hopkins đến với Việt Nam, và song song khi làm việc đó thì chúng tôi cũng mong muốn học hỏi từ phía Việt Nam mình. Thì một lần nữa tôi cảm ơn. To wrap up this session, Nick and Emmy, we really appreciate your participation and contribution. I think the audience learned a lot, and they also have a lot more questions. So if you don't mind, we may need to follow up with you with questions, and hopefully we one day use your technology or the platform in Vietnam and other developing countries. So thank you.
We hope so too.
Thank you for inviting us.
Yeah, thank you. Thank you very much, John.
Thank you. Thank you all.
Yes, thank you all. Very informative, and I think a really potential application. And I think Vietnam, as well as other developing countries, will really want to optimize the screening and surveillance with the integrating of new biomarker like this. Yeah, thank you so much. And please have a great day in USA and great evening in Vietnam. So thank you all.
Thank you so much. Bye-bye.
Bye.
Yes, bye-bye.
Bye.
Thank you, Trung, again.
Dạ,
Okay,
cảm ơn anh Trung, cảm ơn anh Doãn, các anh chị em. Chủ đề hôm nay rất là khó nhưng mà cũng rất là hay, học được rất là nhiều. Cảm ơn mọi người nhiều ạ.
Cảm ơn Hằng nhiều nha.
Cảm ơn.
Bye bye.
Bye bye.